Hello, welcome back to our afternoon session. I've been joined by my colleague, Dr. Buddy Poggi, who will serve as a co-moderator for the abstract portion of this program, and he is going to take off and introduce our next speaker.
Pleasure to have everyone here. Thank you for joining us. I'd like to welcome and congratulate freshly minted Dr. Casey Bedard. Dr. Bedard is a board-certified behavior analyst and international behavior analyst from the Chicago School of Professional Psychology. Dr. Bedard specializes in the treatment of behavior problems and the development of early childhood interventions for patients with Prader-Willi syndrome. She will discuss the effectiveness of treatment protocols for managing weight and behavior in adults with Prader-Willi syndrome based on archival data. Please join me in welcoming Dr. Bedard.
Hi, everyone, and thank you so much for that wonderful introduction. I really appreciate the opportunity to be here and to present for you today. So can everybody hear me okay? I'll take that as a yes. So the study I'm going to present to you today demonstrates the historical effects of a behavioral and dietary management residential program that was specific for adults with PWS. So I'm sure you're all aware of the various problem behaviors that individuals with PWS can struggle with. Although food seeking and food stealing are often at the forefront of research and discussions regarding PWS, tantrums, self-injury, repetitive and rigid behaviors, as well as the aggression and self-injury especially, all present barriers to independence and quality of life in their own right. And they can put the health and safety at risk, not only for the individual, but also for the people who are responsible for taking care of clients with PWS. So there's unfortunately only a very small body of research evaluating the efficacy of various behavior analytic interventions on challenges seen in PWS, and much of what does exist is not particularly recent. The research that does exist supports the use of interventions such as differential reinforcement, functional communication training, discrimination training, teaching alternative and replacement behaviors for weight management, as well as for food stealing, skin picking, and other behaviors such as rectal picking. So for this study, we pulled the archival weight and behavioral data for adults with PWS residing at the Arc of Alachua's residential program. In order to be included in the analysis, participants had to have been residing at the program for a minimum of 6 years, and they needed not to have any absences spanning 6 months or more during this 6-year period. So we ended up with data sets from 45 individuals. 24 were women and 21 were men, and they were aged 20 to 57 years. So I'd just like to start by briefly describing the program before I move into the analysis, just so that you have a general idea of what was included. So the diet and weight management portion of the program starts with a general platform of a physician-prescribed calorie diet. Naturally, there are appropriate precautions in any food environment, which includes things like locks and alarms and supervision, all of which are fairly common in PWS programs. Clients are also able to earn additional calories for the completion of exercise routines. And then for me, the most exciting aspect of the program, or the most interesting aspect of the program, is the inclusion of skills training on appropriate behaviors around food, which includes meal planning, measuring, cooking, and other behaviors and that topography. So this is considered within the behavioral programs, it's considered training of alternative or replacement behaviors for food theft. And the aim is to build skill sets around food needed not only for the clients to stay healthy, but also to empower choice and to increase independence. So the foundation of the behavioral intervention aspect of the program is a token economy that uses calories as tokens, essentially. So for those of you who aren't terribly familiar with token systems, they're simply systems that use quote unquote tokens that can be earned for specific tasks or behaviors. and then traded in for what we call like a terminal reinforcer, which is some set of desired items. Just to give you like a broad scale example, our entire financial system is essentially a token system that uses paper money. So this token system includes DRO and DRA contingencies. DRO stands for differential reinforcement of other behaviors, which includes reinforcing the absence of a specific problem behavior. And then DRA stands for differential reinforcement of alternative behaviors, which means that a specific appropriate or alternative behavior is reinforced. In the case of this program and this intervention, it was things such as exercise and meal planning and a variety of other appropriate behaviors that were specified per client. And then we have the final main component of the program, which targets tantrum de-escalation. And this included some combination of like shaping and reinforcing a functionally equivalent response to the tantrum, as well as prompting and reinforcing solitary calming activities. And then of course, like minimizing attention, maintaining safety, lots of the other ways that we commonly use to handle escalated behavior. So data were collected from 2 different time periods. We collected a 12-month span that was between 2013 and 2014, and then a 12-month span that was between 2018 and 2019. So we had a 6-year period in the middle. We looked at the data on weight, exercise completion, as well as the behavioral topographies as they were defined within the program. All right, so now I'm going to move on to the findings. So this table gives you the general demographics for the individuals that were included in the archival analysis. These clients had resided in the program for a mean of about 15.5 years, and the range was anywhere from 6 years to 28 years. The low range was 6 years, of course, because we required participants to have been in the program for at least 6 years in order to be included in this data set. So in regards to the participants' weight, individuals lost an average of 12 pounds over the six-year period, with a range of 86 pounds lost to 41 pounds gained. The weight gain that's described here was predominantly attributed to time outside of the program, such as holidays and home visits, which of course is the case with the majority of individuals who reside in a residential program. And then we also conducted a paired samples t-test on these data to evaluate the change in weight, and this was found to be statistically significant. So this table describes the number and percentage of individuals who engaged in each of the behavioral topographies that we included. In order to be included in the table, they had to have engaged in the behavior at least once during the 6-year period. So unsurprisingly, the food stealing was the most prevalent behavior, followed by the tantrum behaviors and the skin picking. And then some of the other behaviors, such as the rectal digging and the rumination, were really very rare, with only 4% of the population having demonstrated this at least once during that 6-year period. So we also conducted some statistical analyses on the behavioral topographies, the ones that had sufficient data sets in order to have a meaningful analysis. So this table describes the results of the Wilcoxon's matched pairs test and the effect sizes for the behavioral comparisons. And as you can see, all of the comparisons were found to be significant, meaning that there was a statistically significant reduction in these behavioral topographies from year 1 to year 6. So theft, rectal digging, coprophagia, and rumination were not included in the statistical analyses. As you saw a couple slides ago, we had a very small percentage of participants who engaged in these behaviors. So we looked at the clinical significance instead. And as you can see, there was a very large clinically significant difference in the reduction of these problem behaviors, especially when it comes to self-injurious behavior like rectal digging, and other behaviors that can cause health risks like rumination and coprophagia. So the results of this study were pretty neat, in my opinion. They indicate that the interventions included in the treatment protocol were effective not only in managing weight, which can be one of the biggest struggles within PWS, but also in managing the food stealing. And because food stealing is a covert behavior, Managing that behavior can be difficult because behaviors that are covert in nature are naturally difficult to detect and therefore difficult to manage. The results also indicate that the intervention was effective in reducing the behavioral challenges to a statistically and to a clinically significant degree. And these improvements were seen even in behaviors that are commonly conceptualized as having an automatic function. So things like skin picking and the rectal picking, which within the behavior analytic literature are often quite difficult to control. Additionally, this treatment program was also able to reduce weight and food theft, all while teaching adaptive skills. So it's not just that access to food was completely blocked. They're actually trying to teach the adaptive skills that increase independence. So for example, teaching these adaptive skills was allowing like increased choice, increased independence, as well as giving the opportunities to have appropriate degrees of control in a stepwise fashion based on progress in regards to things like meal planning, teaching, and cooking skills. So archival data comes with its limitations, specifically the inability to evaluate the individual contingencies. So future research really needs to look at evaluating the individual components that were included in the ARCS program to tease out which of those components is the most effective. We could only look at the treatment as a whole. And then I would have liked to look at weight in terms of BMI versus just pounds lost, because I think I didn't quite accurately capture some of the progress of certain individuals. And then finally, of course, when you look back on data that was collected over a time period where you're not doing an experimental intervention, you can't look at the treatment fidelity for the training and the evaluating the competency within the treatment protocols. However, this program, of course, has its own measures or internal measures for training and evaluating competency. And some variability in implementation is anticipated in large programs with multiple staff who are implementing a program. And in my opinion, interventions need to maintain a sufficient amount of efficacy to allow for a degree of implementation error if we're expecting them to be used practically in large programs or pretty much with any practical application. All right, so I'll go ahead and that's the end of my presentation. So just let me know if anybody has any questions.
Hi, thank you so much. That was a wonderful presentation, fantastic data. Right now, we can accept some questions. We don't have anything in the question bank at this point in time, but I think we can give some people some time to answer some questions and to add them into the chat. Dr. Poggi, do you have any questions to ask?
Yes, thank you, Dr. Bedard. Excellent presentation. I think this is a interesting set of data. I think that there is some interest in trying to, manage hyperphagia behaviors as well as kind of emotion dysregulation behaviors. And your data seem to kind of show, kind of a ubiquitous effect, kind of both types of behavior, if you would, although I'm sure functionally they're connected. So that was quite encouraging. This is I think a strong support for this model. And I wonder, do you have any comments about that, about how programs can be more individually tailored for specific behaviors? You mentioned that some of the behaviors you modified were in this data set typically difficult to detect and to intervene upon. So any thoughts about that basic distinction?
Sure. Yeah. I mean, I think the biggest benefit for this program was that all of the clients were receiving behavior services. So the ability to try a bunch of different interventions and then monitor their effect was highly beneficial for the clients. And I know that not all residential programs are always able to get behavior services for their clients with PWS. Things like token systems are formatted in such a way that you can apply them to essentially anything. And as long as you get the reinforcers right, and the frequency and the reinforcers right, then you're going to have pretty much a large scale effect on any behavior that you're trying to implement. But I think the difference between treating things like food stealing and treating things like tantrum behaviors is the food stealing component. I could be mistaken, but I think in a lot of situations, individuals with PWS are just not really allowed that access to food and meal planning. It's like, I'm going to serve you what I think is appropriate, and you're not going to have any say in that. So I think when it comes to teaching, to managing the food stealing and to managing the weight, as well as to a certain degree managing the tantrum behaviors that are related to the food, the really important aspect of this program was the skills training. So the fact that this program is able to teach people the skills to add a little more independence. And just to give you an idea, some clients, when they came in, had very little control of their food, like whatsoever. But then as they continued in the program, they were able to demonstrate that they could have additional independence around food. And this program has clients who are able to plan a meal and cook a meal and do their grocery shopping with a high degree of independence. So as a behavior analyst, my goal is always to find the program that is the most effective and also the least restrictive. So to me, this took away a lot of those like common restrictions that you see with people with PWS, where they have no control over that whatsoever, while still demonstrating that while allowing these freedoms and teaching these skills, we can still keep good control of things like the tantrum behaviors that we often associate with a little bit more freedom around food.
Thank
All right,
you very
so
much
we
for those
did-
comments.
Yeah, we do have a few questions. We had one question regarding your data split tables. Is the D for Delta, and were those percentages?
I'm sorry. Can you repeat that question?
Was that there were a D? Was there a D for Delta on your slides? And was that in percentages? I think it was.
Some of the data were in percentages, and then the D on one of the tables was for the effect size for Cohen's D.
Oh, right. Okay, that's right. I have another question. Is the calorie token system common in other PWS programs? They were wondering how you selected it and to what degree it was considered evidence-based or experimental.
Sure. So I can't take credit for starting to implement this program at the ARC. This program was at the ARC around at the ARC for years and years and years before I started. So I can't say exactly how the beginning of that was selected. And to my knowledge, I do not know of any other programs, I could be incorrect, that are implementing this particular program. And from what I understand, the ARC started just with one person with Prader-Willi syndrome. So and there was not a whole lot of research around. At that time, there were a couple of very minimal articles looking at how to manage food stealing, but those were mostly using punishment procedures, which are not ideal. So my guess is that the ARC chose something that they felt was reinforcing, which would be additional calories, and created a system on top of that. And in situations like this where there isn't really evidence-based practice because there isn't sufficient research in PWS, most unfortunately, and we're trying to change that in the behavior analytic community. So we have to create evidence-based practice based on that individual's data. So you try a program, you look at the behavior change, and you decide if that can be evidence-based with that individual.
Great, great. Now, one other question was with respect to the the duration in the program and the impact on weight loss. Were the people who were there longer, did they lose more weight than the people who were not in there as long, or was it vice versa?
Yeah, that's a great question. So yes, the individuals who are in the, and actually, if I could do this again, I would go back and also look at the data for the first 6 years that a person's in a program. So we required them to have been in the program for at least 6 years, up until however many years they had lived there. And I think that that we didn't capture some of the actual rates of weight loss, because people who are in the program the first 3 years tend to lose the most amount of weight. But yes, the participants who are in the program longer tend to have lost the most weight, and then also tend to be maintaining their target weight range, versus the ones who come in are doing the most rapid weight loss, if that makes sense.
Fantastic. I think we have to wrap it up. This is